Okay, you've handed us the blueprint, and today we're doing a deep dive straight into a topic that, well, it shows up a lot in emergency situations. Pericarditis in dogs and cats.
That's right.
We've got these clinical sources you sent over, and our mission really is to pull out the most critical stuff, the need-to-know info so you really understand this condition.
Exactly. And pericardial disease, which includes pericarditis, it might only account for maybe 5% of heart issues in dogs.
Only 5%. Seems low for an emergency staple.
Well, it is, and it's even less common in cats, significantly so. But it is high on the emergency list because when it happens, it often leads to really serious problems.
Right, and that leads us to the core issue, doesn't it?
Yeah.
Cardiac tamponade. So let's start right there. What exactly is tamponade, and why is it such a big deal, such an emergency?
Okay, so think of the pericardium. It's like this tough little sac around the heart.
Right, the sac.
Tamponade is when fluid, could be blood, could be other fluid, builds up in the space between the heart muscle itself and that sac.
Okay.
And as more fluid gets in there, the pressure inside that sac just skyrockets.
Ah, so it's like the heart is being squeezed from the outside. It's getting tighter and tighter.
Precisely. That rising pressure starts squishing the heart chambers. They can't fill up properly with blood, especially the right side, the right atrium and ventricle, because their walls are thinner.
So the pump just can't get enough fuel, basically.
Yeah, it really cripples the heart's ability to pump blood out.
Yeah.
And here's the critical point, the thing the sources really hit home on.
Okay.
If that pressure inside the sac, the intrapericardial pressure, climbs higher than the pressure in the big veins trying to bring blood back to the heart.
The central venous pressure.
Right, the CVP.
Yeah.
If the sac pressure stays higher than the CVP continuously, even for just, a few minutes, it can be fatal.
Wow. Just a few minutes.
The heart literally can't get the blood it needs to pump. It starves the pump.
Okay, so it's all about that pressure dynamic and how fast it tips over. The sources also mention something called pericardial constriction. How's that different?
Yeah, constriction is, it's much less common, especially as an acute emergency. With constriction, it's the sac itself, the pericardium, that becomes thick and stiff.
So it squeezes the heart even without a ton of fluid.
Exactly. It sort of clamps down. It's often more of a long-term thing, maybe developing after chronic inflammation, like from an infection that wasn't fully cleared, or sometimes for unknown reasons.
And here's a really interesting point the sources brought up. The actual signs you see in the animal often relate more to how bad the tamponade is or the constriction.
Right, the severity of the mechanical problem.
Rather than what's actually causing it underneath. So like inflammation versus cancer could look really similar when they first crash.
That's exactly right. The body's reaction to the heart not filling properly, well, this goes pretty much the same, regardless of whether it's inflammation or a tumor causing the fluid buildup.
That must make the diagnosis tricky initially.
It definitely does. Figuring out the why behind the what's is a major challenge.
Okay, that definitely sets the stage. So let's talk about who gets this. Are certain animals more prone?
Yes, there are some patterns. For what we call idiopathic hemorrhagic pericarditis, that just means bleeding into the sac for no known reason.
Idiopathic unknown cause.
Right. That specific type seems to be more common in younger to middle-aged dogs, and particularly large breeds.
Ah, the big dogs again.
Yeah, the sources list breeds like Great Pyrenees, Great Danes, St. Bernards, Goldens are mentioned too.
Okay, so big dogs, that specific bleeding type. What about infections causing pericarditis?
Infectious pericarditis is pretty rare overall,
Okay.
but when we do see it, it tends to be in younger, active dogs, sometimes cats, but mostly dogs. And there's often a connection to some kind of penetrating injury,
Like what?
like a sharp stick or maybe a plant on, like a foxtail, something that gets into the body, maybe inhaled or through the skin, and then migrates.
Migrates, all the way to the heart sac.
Yeah, it sounds bizarre, but these things can travel through tissues and end up in the chest cavity near the heart, carrying bacteria or fungi with them.
Wow. A simple grass seed causing a life-threatening heart condition. That's unexpected.
It really shows how these odd pathways can lead to serious trouble. Now, switching to cats for a second.
Okay.
Pericarditis itself, causing major signs, is really quite rare in cats. But when it does cause significant problems like effusion, the most common culprit is feline infectious peritonitis, FIP.
FIP. Always tricky.
And FIP has that weird age pattern, doesn't it? The sources call it a dual peak incidence. It hits very young cats, like kittens, but also older cats.
So you can't rule it out based on age alone if you see signs in a cat.
Exactly.
Yeah.
Young or old, if a cat has signs suggesting pericardial trouble, FIP has to be high on your list.
Okay. And there was another key point about cats and fluid around the heart. A distinction.
Yes, and this is really crucial, easy to get wrong. It's actually pretty common to find small amounts of pericardial fluid on an ultrasound in cats that have hypertrophic cardiomyopathy, HCM.
The common heart muscle thickening disease in cats.
Right. Especially if they're in heart failure from their HCM. You might see a little bit of fluid around the heart.
Okay.
But that small amount of fluid, usually without causing tamponade, that's not the same thing as primary pericarditis causing an emergency. It's more of an incidental finding related to the HCM heart failure. Don't confuse the two.
That's a super important distinction. Not all fluid is an emergency pericarditis issue in cats.
Good point. Okay, so let's shift to what you'd actually see. What are the clinical signs if an animal is suffering from significant pericardial disease, especially tamponade?
Well, in cats, again, rare, but signs are similar to dogs when they occur.
Okay, focus on dogs then, where it's more common.
Right. In dogs, the signs all come back to that restricted heart filling, that poor cardiac output we talked about.
What does that look like to an owner or on exam?
You'll often see signs of low blood flow, low output. So things like sudden collapse or profound weakness, they might stop eating, anorexia. The sources also mention prerenal azotemia.
Which means basically the kidneys aren't getting enough blood flow, so they can't filter waste properly, and you see waste products build up in the blood.
Okay, so collapse, weakness, poor kidney function due to low flow. What about the backup pressure?
Right. The high central venous pressure, the blood backing up because it can't get into the heart easily. The most obvious sign of that is usually ascites.
Fluid in the belly, that pot-bellied look.
Exactly. That fluid accumulation in the abdomen is a big sign of that backup.
Is there any physical exam finding that really screams tamponade?
There is one classic, highly suggestive finding. Pulsus paradoxus.
Pulsus paradoxus. Sounds dramatic.
It kind of is. It's where the strength of the arterial pulse, the pulse you feel in the leg, gets noticeably weaker when the animal breathes in.
Weaker on inspiration. Why?
Because when they breathe in, the negative pressure in the chest normally helps draw more blood into the right heart. But with tamponade, the heart is already squeezed, so that extra incoming blood makes the right side bulge more into the left side, reducing left-sided filling even further for that beat, so the pulse weakens.
Wow. You can actually feel the pulse fade with each breath. That really paints a picture of the mechanical squeeze.
It's a very, very telling sign if you can detect it. It strongly points towards tamponade.
Okay. What else might you find on exam?
Other common findings, muffled or distant heart sounds when you listen with a stethoscope.
Because of the fluid insulating the sound.
Yep. Also, jugular venous distension. You might see those big veins in the neck bulging. And usually a fast heart rate, tachycardia.
But the sources warn these aren't specific, right?
Correct. Muffled heart sounds, big jugular veins, fast heart rate. You can see those with other heart or circulatory problems. They're common with tamponade, but not unique to it. Pulsus paradoxus is the more specific one.
Got it. And what about the signs of constriction, the chronic thickening one?
Constriction signs tend to develop more slowly, more chronically. Ascites, that belly fluid, is still often really prominent because that central venous pressure stays high all the time.
Still the backup issue.
Yeah. And in really rare, long-standing cases of high CVP, it can actually start to affect the intestines. You get things like intestinal lymphangiectasia and protein-losing enteropathy.
So the gut starts leaking protein because of the pressure.
Basically, yeah.
Yeah.
Chronic pressure messes with the gut's drainage and absorption.
Okay, so ascites is key for both acute tamponade and chronic constriction. But the long-term gut stuff is more a constriction thing.
Right. Let's dig into the why. What actually causes these problems? We touched on idiopathic bleeding and infection.
Right, so the most common one in dogs, that idiopathic hemorrhagic pericarditis bleeding for unknown reasons, it's still, well, idiopathic. We don't know the exact trigger.
But the sources mentioned a potential link?
Yes, a slightly worrying one. They suggest it might be the benign end of a spectrum.
A spec where the other end, the malignant end, is a type of cancer called mesothelioma.
A cancer of the lining cells affecting the pericardium.
Exactly. So there's this lingering question. Is some idiopathic effusion actually an early undetected mesothelioma or related somehow? It's a possibility that's out there.
That definitely adds a layer of concern to the idiopathic label. Okay, what about the confirmed infectious causes?
For infectious pericarditis, we're talking bacteria or fungi getting in there. The sources listed several: tuberculosis, coccidioidomycosis, that's valley fever fungus, actinomycosis, nocardiosis, pastorella species, quite a few bugs.
And how do they physically get into the pericardial sac?
Often it's those migrating foreign objects we mentioned earlier.
The plant-ons, twigs.
Yeah, or porcupine quills are another classic one. Sometimes projectiles, maybe even bits from previous surgeries or implants. They basically track infection along with them as they move through the body tissues and into the chest.
Just incredible that something so small can travel like that and cause such havoc. And for cats, you mentioned FIP and trauma. Any other infections listed?
Yeah, for cats, besides FIP, they listed things like Staphylococcus aureus, E. coli, Streptococcus, actinomyces, Cryptococcus, another fungus, and maybe even Toxoplasma.
So, quite the rogues gallery of potential pathogens.
That's okay.
We know what it is, who gets it, what it looks like, and some of the whys. Now, the really critical part, how do you actually diagnose this? How do you sort through all those possibilities? It seems like the diagnostic path could be really complicated.
It absolutely is, and the sources really underscore the challenge of the differential diagnosis. You see an animal collapse, weak, maybe with a swollen belly.
You think pericardial disease first, maybe?
It's high on the list, but you have to keep a lot of other conditions in mind that can present very, very similarly.
Like, what else needs to be on that list?
Well, first, other things that cause pericardial fluid or tamponade, besides the idiopathic or infectious types we focused on. Think different kinds of cancer around the heart, like hemangiosarcoma is a big one.
Right, cancer.
Or a rupture of the heart wall, usually the left atrium. Heart failure from other causes can sometimes lead to some effusion, congenital problems like a hernia between the abdomen and the chest near the heart, or simple fluid-filled cysts on the pericardium.
Okay, so other reasons for fluid in the sac. What else mimics the signs?
Right, things that cause similar signs like collapse or belly fluid, but aren't primary pericardial problems. So other types of severe heart failure, cardiomyopathy, valve disease, myocarditis, severe lung disease causing heart strain called cor pulmonale, even severe left-sided heart failure backing up.
Okay, lots of heart stuff. Anything else?
Yeah, other causes of fluid in the abdomen, different cancers causing bleeding or just severe hemorrhage from something else, or conditions where the blood protein gets critically low, like severe liver or kidney disease.
The low protein lets fluid leak out.
Exactly. And then other reasons for collapse or a weak pulse that aren't heart-related at all, things like severe shock, Addison's disease, hypertenocorticism, or serious heart rhythm problems, arrhythmias.
Wow, that is a long list of possibilities. So where do you even begin the workup? Are standard blood tests, urine tests helpful at all?
Generally, the sources say
Yeah.
not very helpful for figuring out the specific cause of the pericardial issue.
Okay.
Your routine CBC, blood chemistry, urinalysis, they often just show non-specific things you see with lots of chronic illnesses or stress. Maybe mild anemia, maybe changes in white blood cell counts like neutrophilia or monocytosis, nothing that points directly at the pericardium.
So basic labs usually don't give you the answer. What about imaging? Chest x-rays?
Chest x-rays or thoracic radiographs are also often, let's say, unhelpful, especially in the acute setting.
Really? You wouldn't see the heart looking big?
You might, if there's a lot of fluid that's been there a while and stretched the sac, you might see a big, round, globoid heart shape.
Yeah.
But often, especially if it happened quickly, the silhouette can look surprisingly normal. And crucially, a normal-looking chest x-ray absolutely does not rule out life-threatening tamponade.
So x-rays are pretty unreliable for catching acute effusion. What is the go-to test then?
Echocardiography, ultrasound of the heart. The sources are very clear. Echo is the best single test to confirm or rule out pericardial effusion.
What do you see on the echo?
You see the fluid directly. It shows up as a black, echo-free space between the heart muscle wall and the pericardial sac. You can see exactly where it is and estimate how much there is.
And can the echo tell you if that fluid is actually causing tamponade? If it's squeezing the heart?
Yes, it's very good for that too.
Yeah.
You look for signs of diastolic collapse.
Diastolic collapse.
Yeah, when the heart relaxes to fill that diastole, if the pressure outside is too high from the fluid, it pushes in on the heart walls. You often see the right atrial wall or the right ventricular free wall actually collapsing or buckling inward during diastole.
Because they're being squished.
Exactly. You might even see this collapse lessen a bit when the animal breathes in as the pressures shift slightly. Seeing that collapse is a strong sign of tamponade physiology. The sources do add a note of caution, though. Identifying actual tumors or masses inside the heart or pericardium on echo takes a lot of skill and experience.
Right. Echo is key for fluid and tamponade signs, but spotting the cause, like a tumor, might need an expert eye. What about measuring pressures directly?
Yeah, hemodynamic measurements can nail the diagnosis of tamponade, provided the animal isn't, say, severely dehydrated or hasn't been given diuretics, which would lower the pressures artificially.
Okay.
Normally, tamponade means high central venous pressure, the CVP, usually over 10 millimeters of mercury. If it's borderline, maybe just a bit high, you can do a fluid challenge.
Gave fluids quickly.
Right, like a rapid IV bolus of, say, lactated Ringer solution,
Yeah.
maybe 10 millimolts per kilogram. If tamponade is present, that CVP will shoot up significantly and stay high. If there's no tamponade, the CVP might rise briefly, but should come back down quickly.
A dynamic test. And diagnosing constriction with pressures.
That's much more complex, usually needs specialized cardiac catheterization. You're looking for pressures in different heart chambers to become almost equal during diastole, showing that the whole heart is being squeezed by that stiff sac. Definitely an advanced diagnostic.
Sounds like it. Any other diagnostic tools? What about an ECG, the heart rhythm tracing?
ECGs can sometimes show changes with pericardial effusion, but they're not very reliable.
What kind of changes?
You might see low-voltage QRS complexes.
Yep.
The main spikes look smaller than usual because the fluid dampens the electrical signal, or it's called electrical alternance.
Alternance.
Yeah, where the height of the QRS spike literally alternates, like tall, short, beat to beat. It happens as the heart physically swings within the fluid-filled sac.
That sounds specific.
It is pretty specific when you see it, but the problem is it's not very sensitive, meaning it's often not present, even when there's significant effusion in tamponade. And low voltage can happen for other reasons too. So ECG findings are interesting if present, but you can't rule effusion in or out based on the ECG alone.
Okay, so ECG suggestive maybe, but not definitive. What about analyzing the fluid itself once you drain it? Can that tell you the cause?
This is where it gets really frustrating, and the sources highlight this big time. Looking at the fluid under the microscope with cytology, it cannot reliably distinguish between the most common causes, that idiopathic hemorrhagic type, and the common cancers, like hemangiosarcoma or mesothelioma.
Wait, really? You drain the fluid, look at the cells, and you still might not know if it's just bleeding versus cancer?
Often, no. The cells in both scenarios can look very similar, mostly blood, maybe some reactive lining cells. It's a huge diagnostic limitation.
Wow. That seems like a massive hurdle when you're trying to figure out prognosis and long-term treatment.
It absolutely is. Now, cytology can still be useful, can help rule out other things. If you don't see cancer cells like lymphoma, or if you don't see bacteria or the specific inflammatory cells of FIP, that's helpful information.
Okay, so it's better for ruling things out than ruling the common things in.
Exactly. And if you do suspect infection based on the animal's history or other signs, you'd absolutely send the fluid for bacterial and maybe fungal culture. Taking an actual tissue biopsy of the pericardium itself for histopathology is another way to get a diagnosis, often done during surgery.
A biopsy, right. Is there anything else maybe from blood work that helps differentiate?
Yes, there's one more clue the sources mention from a blood test. Cardiac troponin I.
The heart muscle damage marker.
Right. They say that a significant elevation in serum cardiac troponin I is not typical of the benign idiopathic effusion. If you see really high troponin levels, it strongly suggests there might be underlying heart muscle involvement, often from hemangiosarcoma invading the heart.
Okay. So while the fluid cytology is tricky for telling idiopathic from cancer, a very high troponin I level in the blood points more towards hemangiosarcoma. That's a really useful piece of the puzzle.
It is. It's not perfect, but it's a strong indicator.
Okay, so we've navigated the tricky diagnosis. We found the fluid. Maybe we have some clues about the cause. What can actually be done? What's the treatment?
For the immediate life-threatening problem of fusion causing tamponade, the sources are absolutely emphatic. Pericardiocentesis is the only effective treatment.
Sticking a needle in and draining the fluid.
Exactly. You have to physically remove that fluid to relieve the pressure on the heart. That allows the heart to fill properly again and start pumping effectively. It's life-saving.
Get the pressure off fast.
Right. Now, until you can get that needle in and drain the fluid, giving IV fluids cautiously can help.
Fluids, even though there's fluid already there.
Yeah, it sounds counterintuitive, but giving IV fluids helps boost the pressure inside the veins and heart, helping to counteract the pressure outside the heart from the tamponade. It supports cardiac output temporarily.
Okay, fluids to support pressure until you drain. But what about diuretics? Drugs to make them pee out fluid.
Absolutely contraindicated. Do not give diuretics like furosemide.
Why not? Seems like less fluid would be good.
Because diuretics work by reducing the total circulating blood volume. In tamponade, the problem isn't too much overall volume. It's that the heart can't accept the volume that's there because it's being squeezed. Reducing the volume further just makes it even harder for the heart to fill against that external pressure. It actually worsens the tamponade effect.
Okay, that makes total sense when you frame it that way. Don't dry them out.
Oh,
So pericardiocentesis is the key immediate step. You drain the fluid. What happens then? Does it just fix itself?
sometimes, for the idiopathic hemorrhagic type, it might. The effusion might resolve on its own after one tap, or maybe it comes back once and needs a second tap and then it stops.
Okay.
However, if it keeps recurring, especially chronically, the sources often use a guideline like, say, recurring more than twice and you haven't found a clear underlying cause like cancer on echo.
Then what?
Then surgery is usually recommended, specifically a partial pericardectomy.
Cutting out part of the sac.
Exactly. You surgically remove a window or a significant portion of the pericardial sac.
Why does that help?
Couple of reasons. First, you get tissue samples. You send the piece you removed for histopathology to get a definitive diagnosis, and the surgeon can look around inside the chest for any obvious causes, like foreign material. Second, by removing part of the sac, you prevent fluid from accumulating under pressure again. If fluid still forms, it just drains into the chest cavity where it can be absorbed, rather than squeezing the heart.
Ah, it creates an escape route for the fluid.
Right. And it might also help prevent that long-term complication of the sac thickening and causing constriction later on. There's also a less invasive option mentioned, thoracoscopic pericardectomy, using cameras and small instruments, which can achieve similar results if done by someone experienced.
So surgery provides diagnosis, prevents recurrence of tamponade, and maybe prevents constriction. What about if you know it's infectious pericarditis?
For infectious cases, the recommendation is generally to do surgery, like a pericardectomy, as soon as you diagnose it.
Go in early.
Yeah, the idea is to debride the infection, remove the infected material and fluid, and open up the sac early to try and prevent that inflammatory process from leading to chronic thickening and constriction down the road.
Okay, so early surgery for infection, and if constriction is already developed, that thickened, stiff sac.
That's the toughest scenario surgically. Treatment might involve a procedure called epicardial stripping or decortication.
That's intense.
It is. It involves meticulously peeling off that thickened, constricting layer of pericardium directly from the surface of the heart muscle, the epicardium. The sources emphasize this is a very difficult, high-risk surgery, really only for specialized surgical experts.
Definitely not routine. Okay, so surgery plays a big role depending on the cause and chronicity. What about medications? Do drugs have a place?
Yes, definitely if there's an infection. You'd use appropriate antibiotics or antifungals, ideally guided by culture and sensitivity testing on the fluid or tissue you collected.
Makes sense. Treat the bug. What about for the idiopathic kind, trying to prevent recurrence?
Well, for idiopathic effusion in dogs, various things have been tried. Anti-inflammatory drugs like corticosteroids, even immunosuppressants like azathioprine, or antifibrotic drugs like colchicine.
Do they work?
That's the question. The sources basically say their effectiveness in preventing recurrence is unknown or unproven. There isn't strong evidence that these medical strategies reliably stop idiopathic effusion from coming back.
So maybe not that helpful for preventing recurrence. Are there any meds to be especially careful with?
Yes, absolutely. We already hammered the point about not using diuretics or drugs that reduce preload, like nitrates, when there's active tamponade.
Right, don't lower the filling pressure.
And also be very cautious with corticosteroids or other immunosuppressants if you haven't completely ruled out an underlying infection. Giving those drugs could potentially make an existing bacterial or fungal infection much worse.
Good point. Don't suppress the immune system if there might be bugs. Okay, so what does follow-up involve after you've treated the initial crisis?
Well, the sources remind us that effusion can definitely recur, especially if the pericardium was left intact, like after just a pericardiocentesis. You need to monitor for that.
Keep checking.
Yeah. And there's an interesting, somewhat concerning long-term note. They mention that sometimes months or even years after an episode of pericardial effusion, an animal might develop pleural effusion.
Fluid around the lungs this time.
Exactly. Fluid in the main chest cavity. And sometimes this late onset pleural effusion turns out to be associated with mesothelioma that maybe wasn't obvious initially.
Wow. So that potential cancer link can rear its head way down the line. That really underscores the need for ongoing monitoring.
It really does. Because of the risk of recurrence or potential complications like constriction or even late findings like that pleural effusion mesothelioma link, Periodic follow-up, especially with echocardiograms, is generally recommended after treatment, even if the animal seems fine initially.
That makes complete sense. You need to keep an eye on things. And thinking about this whole deep dive, it strikes me that when you see an animal come in crashing, maybe weak with a big belly,
Yeah,
it's easy to jump to fluid around the heart as the problem. But what we've really unpacked here is how many different roads can lead to that point, right?
absolutely. Idiopathic bleeding, infection, cancer, constriction.
And how the immediate life-saving step, the pericardiocentesis, is crucial, but it's only the beginning. The real detective work starts then figuring out the why.
Exactly. Because knowing the why, idiopathic versus neoplastic versus infectious, completely changes the long-term plan, the prognosis, everything. You have to look beyond the emergency sign.
It's a fantastic illustration of how conditions that look so similar on the surface in an emergency can stem from vastly different underlying diseases, each needing its own unique approach. It really highlights the layers you have to peel back. Definitely something to keep in mind.